So for the next session, we are really proud to welcome Professor Luca Richeldi, who is Associate Professor of Respiratory Medicine and Director of the Center for Rare Lung Disease at the University of Modena in Italy. Thank you, Professor, for coming and welcome. So the session will be on pulmonary hypertension, and we'll talk about the diagnosis and treatment options of pulmonary hypertension in interstitial lung disease.
Thank you very much. It's always a pleasure to come back to Lebanon and to see many known faces and friends and colleagues sitting in the room. So after the talk of Professor Sidbonis, it's easier for me to put you in the context of how much is challenging when we have patients as a pulmonologist that they also have some sort of pulmonary hypertension. So these are my disclosure for a conflict of interest. In fact, there is nothing really specific to the topic of the talk, and you will see now why. I decided to introduce the idea of fibrosis and pulmonary hypertension with this movie. It's a very nice movie. It's a UK movie, but I think the original book maybe is French. Maybe, yes, that's why. The Dangerous Liaisons. I think it's really putting the point on how much will be difficult to deal with patients when there are some interacting disease in the lung of these patients. So what are we talking about? We're talking about two entities mainly. The first one is fibrosis, pulmonary fibrosis. We call now ILD, interstitial lung disease, but it's useful to know that, of course, Osler, he described basically everything, so it's not a surprise that he also described pulmonary fibrosis, but pulmonary fibrosis was really known since a long time ago, and basically is the fibrotic degeneration of the lung, which is not particularly different from the fibrotic degeneration of any organ, including kidney, including the brain, including the heart, including the liver. But for the concept that we have some more imaging in the lung is more well known that other fibrotic disorder in different organs. And this is what we consider today as being interstitial lung disease. You see, this classification has been made more than 10 years ago, and is going to be revised this year. Tomorrow we will discuss this, the new classification of interstitial lung disease. It's an area which has been expanding, growing, and moving forward very quickly over the last years. But just to give you the idea of what we are talking about a very heterogeneous group of disease. They are very different. And the fact that we are pulled together under the same umbrella of ILD, in a way, it might also be misleading. Why is that? Because inside this group of disease, we have disease with known cause, like typical example is the exposure-related ILD, the occupational, environmental, avocational, the medication-related. These are all interstitial lung disease with known cause. That means when you diagnose one of these entities, you have a very clear-cut way of giving a therapy to the patient, just to avoid the exposure to that antigen or to that medication. So this is one side. The other side is this group. This is a group of very rare or rare disorder, very different from each other. They can go from a very rare like lymphangioliomyomatosis to all the vasculitis, diffuse alveolar hemorrhage, or Langerhans cell histiocytosis, eosinophilic pneumonia. I know you discussed that yesterday with Professor Cordier, neurofibromatosis. These are very different and very challenging in terms of management. In between these, you have these three groups. The sarcoidosis group is just the prototype of any granulomatous lung disorder, which is involving the lung. The connective tissue disease-related ILD, in particular scleroderma-related ILD, is a very well-known entity. And then you have the group of IIP, idiopathic interstitial pneumonia, with this breakdown in different entities. Now, in terms of our topic today, the only entity here that has some sort of approved treatment is scleroderma-related interstitial lung disease. As you know, in these patients, when they present with pulmonary hypertension, there is evidence enough for being treated with endothelin receptor antagonism, in particular bosentan. But for the rest, we will see there is nothing much more. And we have a prototype of this disease. There have been few patients, few doctors taking care of these patients because it's a very difficult field. And this is the typical setting for the ILD, with the doctor sitting behind the computer. I'd like to subject to dozens of tests, which is also happening to our patient, come to very vague conclusion. You know the diagnosis is not always very firm. Try a lot of drugs that won't work and have horrid side effects, and leave you feeling worse than you did before you came to see me. So this has been, so far, the area of ILD and of pulmonary fibrosis. Are we changing this? Yes, a little bit. We'll see that tomorrow. But what about when we look at the prototype of interstitial lung disease, which is IPF? So all of these entities, they have some amount of pulmonary fibrosis. You look at biopsies, and the pathologist will tell you, yes, there is some fibrosis. But the real prototype of ILD is IPF. One, because it's the most prevalent, but importantly, because it's the most well-defined and the one which the worst prognosis. And also is the first one of all the ILD where we have some sort of consensus, evidence-based international and global guidelines. This document has been published in 2011 in the Blue Journal and is an evidence-based document empowering physicians and patients with recommendation for diagnosis and treatment of patients with IPF. And this is becoming, let's so-call, the prototype of all ILD. We hope to have more and more documents like this in other interstitial lung disease, but so far IPF is the only one. So when we talk about pulmonary fibrosis, in general, we talk about IPF. So the problem with IPF is that diagnosing patients with IPF is extremely difficult. Why is that difficult? Because the typical patient with IPF is non-typical, is non-specific. Is typically a male, but it can also have females. Typically around 65 years old, but it can be much younger or much older than that. Has been a smoker, usually, but not always. He presents with dry cough and dyspnea at exertion. That means that most of the time he will end up with the diagnosis of chronic obstructive pulmonary disease. And that's completely understandable. COPD is a very prevalent disease and is characterized by all of these characteristics. It's prevalent in male, typically 65 years old, smoker, dry cough, and dyspnea at exertion. So there is no surprise that all of the patients with IPF have been previously diagnosed with COPD, and they've been treated with COPD. The problem is that these patients, a difference with COPD, they have a much, much worse prognosis. This is the percentage of patients alive 5 years after the diagnosis in different kinds of cancer and in IPF. And you see that 5 years after the diagnosis of IPF, only about 30% of patients are still alive, which is a completely different figure when you compare to the COPD. Because if you look at COPD, the vast majority of your patients will be alive 5 years after diagnosis. So IPF is similar in terms of clinical presentation, similar in terms of symptoms, at least at the beginning, but very different in terms of prognosis. This is because missing a diagnosis of IPF is crucially relevant, because you are not communicating the right diagnosis and prognosis to your patient, and you will mismanage that patient. Then the second component of what we're talking today is the vessels. Of course, I'm not a cardiologist. I will not get into too much details. I will just approach pulmonary hypertension with the view of an average pulmonologist, even less than average, but with the view of a pulmonologist. What you need to know? You need to know that in pulmonary hypertension, of course, there are also guidelines. And our colleagues cardiologists and the pulmonologists, they're expert in pulmonary hypertension, they've been much more effective than we have been in terms of ILD by producing a lot of evidence on how to diagnose and how to treat pulmonary hypertension. This is why this has been, I think, is the third or the fourth version of the ERS guidelines. And these guidelines, they will provide you with a lot of evidence on how to diagnose and how to treat patients with IPF. So the first definition that we need to take into account and we need to keep in mind as pulmonologists is now that we have a very clear-cut difference between PAH and PH. I think it, for the non-expert, is a little bit misleading because they are quite similar. It's just one A more. So it's not so easy, I think, for the average pulmonologist to understand the difference between PH and PAH, but that's a critical difference. Because when we talk about pulmonary hypertension, PH, we define a disease which is characterized by an increase in mean pulmonary arterial pressure of more than 25 milligrams of mercury at rest. It has to be assessed by right heart catheterization. So in the setting where the pulmonologists are not performing right heart cath, like it is the case in Italy, I don't know about Lebanon, certainly you need a strong collaboration with your cardiologist, because there is no way that you have a confirmation of the diagnosis of PAH without right heart cath. And the important thing is that PAH is associated to multiple clinical conditions. If you take the table of that guidelines, it is a huge table, and basically there is no disease without any case report or description of association between pulmonary hypertension and that disease. And it's spanning from infectious disease, from AIDS, towards vascular disease, or portopulmonary hypertension, drugs, and so on and so on. While PAH, it's a very rare disease. It's a totally different disease. I mean, it's characterized by the presence of precapillary PH, but there is no cause for this precapillary PH. So there is no lung disease, there is no thrombin PH or other disease. So this is the truly idiopathic form of pulmonary hypertension, and it's rare, if not very rare, needs to be taken care by very expert centers, but that means that as a pulmonologist or a clinician, most of the time, if not always, you will deal with patients with PH associated with secondary disorders. So now we know more and more by using high resolution CT scan and using echocardiography and right heart cath that the association of interstitial lung disease and vascular disease is probably more common than we thought before. And this is where the connection, it becomes very dangerous, because you have two causes for reduced oxygenation of the lung. On one side, you have the increase in the interstitium caused by pulmonary fibrosis, and on the other side, you have the increase in the pressure. So when we look at the only guideline that we have available in the field of ILD, which are the guidelines on IPF, as I told you before, they've been published in 2011 in the Blue Journal. When you look at the summary conclusion and treatment recommendation, the recommendation is against the treatment of PH associated with IPF. But this recommendation is weak. What it means? It means that it's based on relatively scarce evidence. So the major message that we have from this guideline is that the association of PH and IPF, or ILD in general, so far has not been studied enough. So pulmonary hypertension should not be treated in the majority of patients with IPF, but treatment may be a reasonable choice in a minority. So this is the typical language expression of the grade methodology, which is how we assess evidence, which is helpful in a methodological way, not extremely helpful when you deal with real patients. Because now we know that because the evidence is weak, even if the recommendation is against, a minority of patients might be treated. So now the point is, which minority of patients? When I have a patient in front of me, it's not a minority, it's not a majority, it's one patient. So I need to take a decision in that single patient. That's why these guidelines are very helpful in terms of reassessing the evidence, but not very helpful in terms of practical recommendation. And why we recommended these against? Because patients with moderate to severe PH, they may get a trial of vasomodulatory therapy. However, the real need in the presence of any weak recommendation is the need for clinical trials. And you see that the members were split. 8 were for the use, 14 were against, 1 abstained, and 8 decided to stay at home, just not to take a decision here. So it's not really a black or white decision. We know these drugs are not approved for PH associated with ILD or IPF. At the same time, we have some evidence and some data suggesting that in some patients this drug may help. So should you treat a patient with PH and ILD? This is my personal algorithm that I use in my patient. First, you need to ask yourself and the patient if the patient is interested or eligible for a clinical trial. Let's say that tomorrow you have available a clinical trial of a new drug in patient with PH secondary to IPF. In that case, this will be my first option. Just because we are not in the presence of a strong recommendation. So the evidence available is not enough. That means that both in terms of the single patient and in terms of the community, we need to generate more evidence. If the clinical trial is not available, or the patient is not eligible, or the patient is not interested, then you will need to ask yourself if the risk of the treatment outweighed the benefits. And this is somehow a difficult decision to take. Because if the risk outweighs the benefits, you should take the decision not to treat. So the point of not treating patients with PH and ILD is very difficult. Because we know there are PH drugs approved for PH in other indications and for PAH. So this patient and the doctor will know that the drugs are available. The decision not to use them is a critical one. If you think that the risks do not outweigh the benefits, you treat the patient. Now the point is with what? What we have available so far. So far, this is the classical cartoon that has been showed, I think, from in any single talk on pulmonary hypertension, which is basically is from Mark Humbert. It is basically show the 3 pathways that are the targets of the available therapies, pharmacological therapy for the treatment of pulmonary hypertension. Again, remember that all of these pathways, they have been tested and approved first on PAH, on pulmonary arterial hypertension, the very rare condition. And then now they are going to PH secondary to other disease. Is there anything here that has been tested or proved in ILD? So far we have no strong evidence, because otherwise the recommendation of the guideline will be different, but still we have some cohorts that have been reported, because again the physicians, they try to use these drugs, which is quite understandable. I mean, there is no surprise, there is nothing wrong with that. You try to help a patient which is very breathless, very sick, with a drug that has been approved for what you think is a similar disease. So there is nothing wrong. These are the data that have been reported at the ERS conference last year, significant number of patients, and you see that as always, or in many cases, we see in the patient treated with the drug as compared to patient not treated, there is a decrease in the mean pulmonary arterial pressure, which is statistically significant. That means that these drugs, they decrease pulmonary pressure in these patients. However, when you look at the clinical effect in terms of cardiac index or PVR, there is no difference, and more importantly, 6-minute walking test is not changing. So these patients have a hemodynamic effect by the use of the drug, but they don't walk more. They don't have a clinical effect. And we know that at least for 2 drugs. This is the first one. This is the trial that has been completed in the US by the IPF network, as it was sponsored by the NIH. Is a controlled trial of sildenafil in patients with advanced IPF, double-blind, placebo-controlled, 12 weeks. The primary outcome was an increase of 20% or more in 6-minute walking test, which is something in 12 weeks. So 180 patients with advanced IPF, that means lower than 35% DLCO, without any further demonstration of the presence or the absence of pulmonary arterial hypertension. So we don't know if this patient had pulmonary hypertension. So basically the primary outcome was negative. But if you look at this variable, which is death from any cause, at 28 weeks, the patient in the sildenafil have a 5% mortality against the patient in placebo 13%. Not statistically significant, but still a hint that maybe these patients that can die less under sildenafil, and there's some secondary outcome, including dyspnea and quality of life, that had some effect. After this, we had some negative trial with endothelin receptor antagonists, and this one is the most recent trial that tried one of the endothelin receptor antagonists, which is AMBRISENTAN in patients with IPF. This is a very important trial, at least for 2 reasons. One, because it's providing us with an exact estimation of the prevalence of PH in patients with IPF, and secondly, because of the results. So this study was terminated early at an interim analysis, and we know now that in the mild to moderate patient with IPF, this patient with mild to moderate, that means more than 50% FVC, more than 35% DLCO, all of them have right haircut at baseline. And we know, very important information, that 10% of patients, independent from which arm, they have pH at the baseline. So we know that you take the average mild to moderate IPF patient, 10 out of 100, 1 out of 10 will have pulmonary hypertension, which is quite a sizable figure. Unfortunately, AMBRISENTAN treated subject has significantly more disease progression than patient in placebo. So, and also more respiratory hospitalization. So this is a truly negative trial showing that disease progression is more in patient treated with AMBRISENTAN, and in particular hospitalization, and even that, even not statistically significant, is more in patient treated with AMBRISENTAN. So we know that AMBRISENTAN at least is not a choice in patient with IPF. So we start worrying about, are we causing more harm than benefit when we treat these patients or not? So the information which is very important is that certainly PAH is completely different from PH in ILD or IPF. So we are talking about different disease. At the same time, we know there are a variety of new targets, new molecules, new approach that might in the future, even not so far distant future, have an impact on the treatment of these patients. So, and the combination, as you know, of emphysema, fibrosis, pulmonary hypertension is becoming more and more recognized. as a complex interaction and complex entity. So I would like to leave you with this idea that we have this is a cartoon that is moving inside the community. It's possible that we start with the emphysema, and then in some patients we get the fibrosis, some patients develop PH and maybe cancer after some time. So in terms of the dangerous liaison, I will leave you with this question that I have to you. You have a patient which is a woman. This was a real patient at our institution, 65 years old with IPF. She is dyspnoic, mildly restricted, and she has only coming on high resolution CT scan. She had a right heart catheterization showing that the mean pulmonary arterial pressure was 35 millimeters of mercury. So would you treat this patient with any, I not get into details, would you treat with any of the available drug for pulmonary hypertension on the market or not? Who is for yes? Raise your hands. Not so many people, eh? Who is for no? So I see, after this presentation, I can see your point. However, in the single patient, it's relatively difficult to take a decision. You think about the sildenafil trial, or think about even the bosentan trial where there are some patients responding. So if you answer yes, you have some good reason to do so. You can say, okay, she's symptomatic, maybe I can reduce the breathless. I can a little bit improve the 6-minute walking test. The restriction is mild, so the component due to IPF is probably not so relevant in terms of the impact on symptoms in this patient. She has a moderate pulmonary hypertension, and there are data, we have seen that, they're very low quality, suggesting a benefit. Which are the risks of treating these patients? They are relatively minimal, right? At the same time, you can answer no, and you have good reason to answer no, because the symptoms are likely to be from IPF, because she has IPF. She has only coming on a high resolution CT scan. The pulmonary hypertension is 35 millimeters of mercury, and our colleague cardiologists, they tell you, is not severe, right? There are no good quality data to support the therapy, and there might be some risk. You have seen the AMBRISENTAN trial, minimal to therapy. So I think the true conclusion here is that we don't know yet what to do with patients with pulmonary hypertension and interstitial lung disease. Certainly, we need to recognize them. Hopefully, we need to put them into new clinical trials, but definitely we should share with them the poor prognosis which is related to this deadly combination. Thank you.
Thank you.